Good afternoon, everyone. Let me just take a few minutes and describe what we're announcing today. But just to refresh everybody, we began our patient-centered medical home program on January 1 of 2011, so we have one full calendar year of experience now under our belt, and we've know what the results are for the first year. But just to cite a few statistics, at the present time, there are about 3,600 primary care physicians and nurse practitioners in the program. Well over 80% of all of the practitioners in this area that are in active practice. And the area includes Northern Virginia, Maryland, and DC. The program has just under 1 million people enrolled in it. So we think it's among the largest, if not the largest of its kind in the U.S. Just a couple of other comments. The program causes primary care physicians to organize into small teams, small groupings. These are called medical care panels. And we said to them, if you come into the program, which is entirely voluntary, you have to form a medical care panel. And it can't be any fewer than 5 of you, nor greater than 15 of you. We basically wanted small teams because we thought that would enhance the likelihood of good performance. So today there are just about 300 such panels around the region, 250 or so of which have been in the program for were in the program for more than 6 months in 2011. So this is a pretty big operation. The goal, there were really 2 goals to this whole effort. One was to see whether primary care physicians, if they had the right incentives and supports, and they were organized as a team, could they bend the cost curve? Could they show better cost results than in a completely unmanaged situation? And the second goal was, could they improve quality? And quality is measured in a variety of ways, but we wanted dual achievement. We wanted improvements in quality, and we wanted to see if there was evidence of bending of the cost curve. So with those goals in mind, we asked them to form panels, and for each panel, we took the patients that were in the panel, members of ours, subscribers of CareFirst, and we attributed members to panels by looking at the claims histories of the people in the panel. Which primaries did they actually go to for primary care services? So again, today in the region there are roughly between 2,500 and 3,500 members of ours, subscribers of CareFirst, on average in each one of the panels. And so let's take an average number of, say, 3,000 members. They could be expected to run up between $10 and $12 million a year in total healthcare costs. So essentially what we were saying to the panels was, see if you can beat it. See if you can improve what we would otherwise expect the total costs to be. And do that by taking care of the people who need you the most. These are typically people with multiple chronic diseases. Set up care plans for them, and we will pay you to do it. And then monitor them and make sure that they get what they need. And look at people who have high risk for chronic disease and make sure you help them understand that risk and hopefully mitigate that risk. And do the things that common sense would say might help people get better overall health status and health outcome if they do get sick. So in very brief terms, that's what we set about doing. And we gave the primary care physicians in each panel very strong incentives to pay attention to this. So the first thing that we did was we said, if you come into the program and you agree to essentially 2 things. First, you agree to form a panel and be part of a panel. And second, that you agree to manage people in care plans for people who could benefit from care plans. If you agree to do those things, we'll essentially take what we're paying you now in your fee-for-service relationship with us and we will add 12 percentage points to the fees that we would otherwise have paid you just to come into the program. And if you set up a care plan for an individual, we'll pay you $200 more for the effort and the time it takes to set up that care plan. And as you maintain it with the individual member over time, and you have them come back in and maintain the care plan, we'll pay you $100 extra when you do that. But I think the real award, the real motivation, as important as these things were, the real motivation was to say to them, if you beat the expected costs of care, you perform below what otherwise would have happened for the whole population of your patients for the whole year of 2011, you will get a reward. And that reward could be 1% additional fees to 100% additional fees. It could be a substantial award, depending on how you did. But you had to have acceptable quality scores, and the higher the quality scores, the higher the award you would get. So here we are. We have the results for the first year. And we had to allow one calendar quarter after the close of calendar year 11 to allow all the claims to come in for all the people, all the subscribers that were in the program. And it takes about one calendar quarter for that to happen. So by the time you get to the end of March of 2012, you have 98 to 99% of all of the claims in, and on the strength of that completion, we could do the settlement for each panel. So the question became, against the total expected cost you had for your panel of patients, how did you do? What were the actual costs against those expected costs? And we now know the answer to that, and that's what we're announcing today. So let me give you some of the key, I think, interesting statistics that came out of that experience. And of course, no one knew going in what would actually happen. But here's what happened. There were about 250 panels out of the 300, 253 to be precise, that actually qualified or were eligible for an award because they had come into the program prior to July 1 of 11. So the rule was you had to be in for 6 months or more, because if you were in less than that, it was too brief a period to come to any conclusion. So out of the 300 some odd panels we have, 253 actually met that criteria. Of those, 151 actually earned an outcome incentive award, and that meant that they performed underneath the overall expected costs for their population of patients. So roughly 60% of the panels won in that sense. And 40% of the panels did not achieve that result, that their costs were at or higher than the expected costs of care for their population of patients. So the majority actually are entitled to an outcome incentive award. Now what's interesting about that is that the average award turns out to be approximately 20%. So the way it works is, if you earn the award by performing under the expected costs of care, we will add a percentage related to the degree to which you achieve savings and quality to your fees effective July 1 of 12, and that would continue for one full year through June 30, 2013. So if you're a primary care physician and you had an outcome incentive award because you earned it, your fee increase that you would receive is something, on average in this case, about 20%. So that's on top of the 12% that they got to come into the program. So this becomes very, very meaningful additional income to these primary care physicians. And each year you have to earn it. So we're almost midway through 2012. We'll repeat the process in 12 and 13 and so on. And the more consistent they win, year after year, if you win multiple years in a row, the rewards get bigger. The idea here is take care of the population of patients you have and see if you can save and improve their quality. And if you do, you get stronger rewards. Here's another interesting statistic. The average panel that got an award beat the overall trend in this region, the rise in medical care costs, by about 4.2%. And while that doesn't sound like a huge percentage, in dollar terms, that's very substantial. And the average panel that didn't beat the expected cost of care exceeded the trend by about the same amount, 3.9%. So the spread between the panels that got outcome incentive awards and those that did not is approximately 8%. And that is a very large number when you apply it to the fact that in total, given all of the people who were served through these panels, the total dollar flow of claims that were under the management of these panels was about $2.5 billion worth of claims. So, very substantial number. And these results we will be analyzing. It's the case that all kinds of different types of panels that were already in organized group practices and panels that were formed by solo practitioners getting together. The pattern of wins and losses was pretty much scattered across the region. There was no one dominating pattern. We're analyzing as best we can why the results came out the way they did. This is the first year of a program that is intended to be a multi-year program, and so we want to be a little bit cautious about the conclusions that one reaches based on the first year. Everybody was getting used to the program rules and the way the program operates, and so there was certainly some of that to take into account, but now we're watching closely for the second year, but we're going back and probing what the patterns were, if any, in the first year. So those, I think, are the headlines and the most important things that we would draw from this. What we find is that as the primaries understand better and better the way the program works, they do the things that we were hoping they would do, which would be pay attention to the people at highest risk, pay special attention to the people that have multiple chronic diseases with multiple medications, pay attention to helping them not fall through the cracks in the healthcare system, and you can get a better outcome for them, but you can also get a better outcome in terms of overall cost, and that you will participate in that through these outcome incentive awards. And as they come to learn this and understand this, they seem to be reacting very well to it. So I think that's the essential message, and I'll stop there and be happy to take any questions.
At this time, I'd like to inform everyone, if you would like to ask a question, please press star, then the number 1 on your telephone keypad. Again, that's star 1 to ask a question. We'll pause for just a moment to compile the Q&A roster. And your first question comes from the line of Andis Romanzik from Model Healthcare.
Hello, Andis Robustings with Modern Healthcare.
Yes.
I was just wondering if, I know that you said that there weren't patterns necessarily, but were there any particular areas where the greatest savings occurred? I mean, whether it be diabetics or hypertension or what have you.
Well, I would say this. I don't know that we know that fully yet, but this is what I would observe about it. What we see are patterns of chronic disease, clusters of chronic disease. So it's not atypical, for example, to see not just diabetes, but diabetes in combination with hypertension, obesity, osteoarthritis. In other words, these things tend to appear in clusters. And what is the typical pattern is that people with these clusters of chronic disease also tend to have multiple medications, oftentimes 10 or more prescription drugs they are taking. They get confused, they tend to break down, and there's a pattern of admission, readmission, and ER visits. And since these diseases are chronic, this doesn't go away, and they tend to, over time, get worse. And so I don't know that we can yet isolate, was it the diabetes that was better managed or the coronary artery disease that was better managed, but what seems to have occurred is that the cycle of breakdown, admission, readmission, and ER visit, was lessened for the people who were paid attention to differentially in the program, and particularly the people who are in active care plans, because what we did is we assigned a nurse in the community to work with the doctors. The doctor would tell the nurse what the patient needed. The doctor is the quarterback, but the nurse documented that in a care plan. And then the nurse followed up to see that the patient got the services that they were supposed to get. And again, a year doesn't make a definitive pattern yet, but what seems to have started to occur, which was what we intended, was that these patients were better stabilized and their risks were better mitigated. And it occurred in clusters of chronic diseases that you see commonly in the population. Is that
Okay, thank you.
okay?
Your next question is from Sarah Gintz with 1,000 More.
Okay.
Did you say Sarah Gantz?
Yes, ma'am, your line is open.
Okay. Hi, this is Sarah Ganson from the Baltimore Business Journal.
Hi, Sarah.
Hi. How does the amount this program is saving in patient health care costs compare to the amount that's being spent to pay the doctors?
The amount that's being saved exceeds the amount that's being spent. So the difference between the panels that beat the trend and the panels that didn't is a net savings of about 1.5%. And that was, I think, it sounds again like a small number, but it isn't on the scale that we're talking about. And that, we thought, was an excellent result for the first full year of operation of the program. So it produced a net savings in its very first year.
Do you have a projection of how much you anticipate this to save once it has been in the works for a few years?
Yeah, I think it's interesting because we have the view that it would take on 3 to 5 years for the program to really fully take hold. Let me put it in these terms. If you got a 20% average award here, you won't soon forget it, and you won't want to lose it because it comes up again for renewal in the next year based on your performance, and you might very well be interested in what you can do to improve on that. And if you didn't get one, but 60% did, you'd be interested in, well, what do I need to do to get it? So we think it takes a while for the full dynamic and the full understanding of the program to take hold. And we thought in the years 3 to 5, we would begin to see more material changes in cost patterns. I think I would say in a range, it would not be unreasonable to expect bending of the cost curve by 3 to 5% in a given year. And if that were accumulated over time, it would actually make a huge difference. And we think that really the only way that could be accomplished is the avoidance of the kinds of breakdowns that typically occur, admissions, readmissions, and ER visits. And this is a region that is among the highest, if not the highest in the country in that regard. So if you ask, well, how do you get this done? You basically get it done by taking better care of these people and preventing the breakdowns that would now, typically today explain where the costs are. And so we're watching that very closely. But if we get a cumulative effect of this over time, then I think from society's standpoint, it actually does start to control the rise in healthcare costs, and it does it in a way that is based on physician involvement and engagement in the process. So that would be our general expectation. It's hard to project out with any specificity what the results would actually be. But that's, I think, a reasonable expectation that we have.
Thanks very much.
Okay.
And your next question is from Jay Hancock with Kaiser Health News.
Hi, Chet. How
Hey,
are
Jay.
you?
Good. How are you?
Pretty good.
That's good.
Can you give us a dollar number on the 1.5%? The dollars are big, but it shouldn't be that hard to figure out what they are.
That is a very good question. I think we can get it to you. I'm a little bit reluctant to do it off the top of my head, but I'll have Michael get it to you. Soon after the call.
Okay.
It's in the. It's a big number. It's tens.
Yeah, I assume. I mean, as you said, 1.5% doesn't sound terrific, but with a million members, it sounds like it's
well, $2.5
comes up to a chunk of change.
It does. I mean, $2.5 billion of care was rendered to the people in the program. So roughly, if you took 1.5% of that, you would get.
Yeah. So can we just?
Yeah, I think so. I want
to.
I just want to check
$25 million.
Yeah, something like that.
Okay.
Yeah. And then if I think the point I was trying to raise to the earlier question was, what we're looking to do is have that cumulative. So you bend it not just 1 year, but you keep bending it. And then, so if we got something bigger than that in the second year because there was better understanding and more care plans being done, then it would be cumulative as you go through each subsequent year. You're building on the prior year. You're slowing the rate down on a cumulative basis. And that's where the bigger dollars come from, And it's not coming from any one place. It's savings coming from multiple places.
A couple others, if I could.
Sure.
The 4.4% of the people who were successful, that is net of the bonuses, right?
It is.
Even after you.
Yes. What they did is it is. What they did is they saved 4.4%. It wasn't 4.4% of the people who won, physicians who won. It was the 60% who won were 4.2% lower than the expected cost of care for their panel after all costs were in.
Right, including the incentives paid to the PCP.
Well, the incentives that had been paid were the 12%, and the incentives.
That comes later, right?
And that comes later. So what will happen is that the fees that they earned, the increases that they earned, will start to be occurring July 1 onward.
How much do you think that might shave your savings?
I don't think it will shave much. I mean, the total value of that is about $22 to $23 million, spread over 2.5 billion. And we think that number, will go up because more people are coming into the program. But we think that the dynamics that the program sets in motion, by stabilizing patients at home and taking better care of them, will actually produce savings well in excess of that. So.
Right. So, to make sure I understand, the 1.5% bottom line was about $25 million in savings, but you're saying that the incentives paid to the docs might almost equal that?
No, the savings paid to the incentives paid to the docs will occur from mid-12 through mid-13. They weren't built into that number, and 1.5, Jay, would be more about 40 to 50 million in savings on 2.5 billion. Okay.
Of course.
So.
Yeah, you're right. Okay.
Okay. So.
Okay. I just want to make sure you're not going to reap savings last year and then give it all back.
No, I think
next year. I mean, you could make an argument that that's money well spent, even so. But
well, the whole idea here is incentives affect behavior, and there's no more important behavior to affect than the way primary care physicians pay attention to people with chronic disease. We are a region that has the highest inpatient admission and readmission rates in the country. So if that could be brought down, we think there's huge savings potential. We want to be cautious about what we're projecting, but we think that the incentives here will drive behavioral change with supports. I mean, the primaries are getting support to do this. That could greatly exceed whatever we pay in incentives. Think of it this
Right,
way.
okay.
The way the program is organized is it's important perhaps to say one other thing. You only get paid an incentive if you actually get the cost to be lower than we expected. You don't get an incentive if you don't do that.
Right.
So you have to save something to begin with. About a third of what is saved is what is shared and put into the incentives that the doctors get. So they get about a third of it. And the rest goes back to the premium payer.
Okay. So I'm sorry to belabor this, but I just want to make sure I don't get it wrong. So total savings, the 1.5% is circa $40 million, and total bonuses that the docs earned, at least for the next 12 months, is 22 to 23 million.
Yes.
Is that what you said?
Yes.
Okay. So that's more than a third, but this is the first year, so you see that portion going down going forward.
Yes.
Okay. One more thing. Sorry to monopolize here.
No.
These your baseline here was expected costs for the year. How conservative or liberal were you in looking at what you thought the trend was going to be?
Well, here's what we did. We took 2010 costs. So we took the year before the program started, because that was a year in which nobody managed anything.
Right.
So it is whatever it is, whatever the claims were in that base year, 2010. And then we trended it by what we call overall medical trend. And what overall medical trend is the combination of all price movements for healthcare, all use changes, mix changes in the type of services that people get, and expresses it all in one number. We had estimated that the overall medical trend in this region would be something in 2011 in the 7.5% range, all in, everything in. And it turned out, that it actually was 7.5%. So you had to take your base trended and beat it to get an award.
Okay. But you're saying the base here actually turned out to be reality.
The base was reality. It was what was actually spent for these very same patients in 2010.
Okay.
And then trended by a trend factor that no doctor could control or know. This was what we know because of our experience in the field. We estimated it would be 7.5, and it turned out to be 7.5.
Gotcha.
And then if you beat it by 4 percentage points, you're down in the 3.5% range. And that's a pretty good result. And if you didn't beat it, and you were 4% over or 3.9, you were over 10, 11, and that spread is remarkable. So what we're trying to do is get every panel to pay attention to, how do you look and how are you doing as a panel? Beat your own history. Beat your history trended. Perform better than the region as a whole is what we're saying.
Gotcha. Okay.
All right.
And again, if you would like to ask a question, please press star 1. And you do have a question from Andis Roman, Modern Healthcare.
Hi. Another follow-up. Just can you repeat and kind of explain a little bit more the $100 and $200 payments?
Yes. We say to ask a primary to take a patient that needs a care plan. These would typically be the type of patients that I described, multiple chronic diseased patients. They know who they are, and we know who they are because we have the data that shows who they are. So we asked the primary to set up a care plan. So the primaries would say, this is what they said to us when we were forming the program. They said, well, we see a patient every 10 minutes. In some cases, every 5 to 10 minutes. And if we had to take time to set up a care plan, it takes us away from patients out sitting in our waiting room that actually we don't have the time for, and it costs us money. So we said, well, why don't we do this? We don't want you to do a 10-minute encounter or a 5 to 10-minute encounter on a patient that may need a great deal more. Please take time and please come to a considered judgment about what the patient needs. And if that takes 40 minutes or 45 minutes or whatever it takes, please take it. So what we said to them is, we will pay you for the office visit, as we always would, and then we would add $200 to it for the time it took to develop the care plan. So that's what we've done. And it dealt with their concern that there was an opportunity cost to take so much time for a patient that needed that amount of time. And so for every care plan that gets set up, and the doctor doesn't have to write it out, the nurse will write out the care plan, whatever the instructions of the primary, were. And I want Mary Smith to have this, 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 and this, and the nurse writes that down and then follows it up for the doctor and reports back. So in order to take the time to come to the considered judgment we want the doctor to come to, we pay them this extra $200. Now the care plan is set up, it's active, the nurse is following up with the patient, and at whatever the appropriate interval would be, the patient is called back in for what we call a maintenance visit. Make sure everything's going as intended, that you understand, any complications that are arising or obstacles that are arising, and it's a status check, and it can vary based on the condition of the patient. For that maintenance visit, you get the regular visit fee plus $100. Again, to compensate for the additional time taken on these patients. Now, I probably should say one other thing here, which is that we stratify patients based on illness burden, the level of illness in the patient. And it's the case that just about under 10% of all of the members that we have, subscribers that we have multiple chronic diseases that are sort of an active mode. And they explain just under 30% of all of the payout in medical claims. So typically when a care plan is set up by the doctor with the nurse, it's set up for somebody that fits those criteria. We're not doing care plans on everybody. It's a relatively small percentage of patients, but it's a relatively high percentage of the total medical spend. And we're growing in the number of care plans that are set up, and that will grow all through the course of this year and all through the course of next year. So it puts more and more of the people who have multiple chronic diseases in care plans for their own benefit. Now they have to consent. You can't be put in a care plan without the patient's consent, and so the doctor obtains the consent first. And the vast majority of people consent because they see the benefit. But that's the way it works. Ines, did I answer that question for you?
Yes, thank you.
Okay.
Your next question is from Lena Sun with the Washington Post.
Okay.
Hello?
Hi, Lena.
Hi, Chet. Can you, you're talking a lot in percentages. I was just wondering whether you could give a sort of a typical, in a panel that was getting one of these awards, this 20% average award, if you could put some numbers, real dollars to, for example, this means that the docs in this group would get this amount for this procedure, or, something real other than just percentages.
Okay, well, let me give you just maybe an approximation, but in real dollars. If you took a panel of, say, 8 to 10 primaries, and that panel had 3,000 members of ours, they could expect to have, say, $12 million a year in total care costs. 5% of that $12 million, or thereabouts, goes to the primaries. So it's 5% of 12 million. It's, 600,000 or whatever that number is. I'm doing
right.
That. Okay. 20% added on that.
20% of the 600,000?
Yes. If you got an average increase in fees of 20%. 120,000 for a panel of 10.
Okay, so let me just work backwards. So the 5% is what the typical panel would be their margin.
No. Let's say that a population of 3,000 people can be expected to have $12 million a year in healthcare costs.
Okay.
Of the $12 million in healthcare costs, about 5% of all of those $12 million is for primary care services.
Okay.
Okay, so you could expect that $600,000 out of $12 million in any given year for that population of people, approximately, would be for primary care services.
Okay.
Okay, and that's all fee billed to us by these primaries, and we pay those claims, and they represent about 5% of the total medical spend.
Got it.
Now we're going to say to them, we'll add to what we pay you 20%. If you got an average award.
Okay.
That 20% is another 120,000.
Okay.
For 10 doctors.
For 10 doctors. So then I would suppose if you wanted to split it, say then, if all the doctors were split equally, it'd be an additional $12,000 to the individual doc.
Yes, and then you have the 12% that they get to begin with, to come into the program.
So and that 12% would be the 12% of the 600,000 on top of the 600,000?
Yeah, if you want to think about it that way, yeah. These are all approximations, Lena.
Right.
But it's just to get, the proportions right.
Right.
So the whole idea in a nutshell was, pay attention, because this is not marginal money to you. This could be very material. So take care of these patients well. And if you do, there's pretty strong rewards here. Makes a big difference. So if you believe, and we started out with this belief, that primaries are not, as they say, they feel that they're undercompensated for what they do. And so we wanted to help address that. But we said, we'll do that for value. Take care of these people better. And if you do, and you get a better outcome for the whole group of them, all of your patients, you get a pretty strong reward. And that's exactly what's happened.
Can you just, you mentioned this sort of offhand, why do you think this region, you said it has the highest in the entire country of inpatient and readmission?
Yes.
Why?
I wish I knew the answer to that question. Not entirely sure why. We have had reimbursement policies in the state, in Maryland in particular, but this is true in D.C. as well, so I want to be careful with over-analyzing this or saying that we have the answer. But a fee-for-service based system or a unit charge control system, as is in place in Maryland, tends to reward volume. And we've gotten volume. I don't know whether it's the style of practice. I don't know whether it's financial aspects that have induced it. Nobody is entirely sure. There is no good answer to that question. It's a very good question, but there isn't a very good answer to it.
But you have fee-for-service all over the country.
You have it all over the country. Why would it be higher here is not clear.
Okay. And it's higher in Maryland than it is in D.C. and Virginia?
No, D.C. and Maryland are sort of standouts on these statistics. And it depends on whose data source you go to, so I don't want to say the highest. Some data sets we look at, it is the highest. Others, it's among the top 3 to 5 areas of the country. It's high by any standard. And it's measured by admits per thousand, or days per thousand, inpatient days per thousand, or ER visits per thousand. Those are the typical published benchmarks. And you could look at CMS data, you could look at other industry-wide data, but this region always comes up high.
Okay.
And so so if that, and the inpatient use and hospital-based outpatient use are the most expensive resources there are, and so if there was something that could be done to cut use down, not by underserving people, but by actually stabilizing them and dealing with their risks, you could actually make a productive change. That was the whole idea behind the program, which meant that got you to the question, well, who's in a better place to understand what a patient's needs are, especially if they have chronic disease? You have diabetes with obesity, with hypertension. That's exactly what a primary is best at dealing with. And so that's why we said the primaries are the ones here that know the patients the best, are most trusted and listened to by the patients, and who actually are in the best place to set up care plans. Let us help them do it, and let us reward them if they get a better result.
Okay.
Again, if you would like to ask a question, please press star 1. There are no further questions at this time.
Okay, well, thank you all very much. Glad we could do this, and be happy to take any other questions if you happen to think of them later on. You can call Michael, and we'll get you whatever information you'd like. Thank you, everyone.